We have Kathy Smolinski, who is an associate clinical professor and the director of the Legal Advocacy for People with Cancer Clinic at Wayne State University Law School, and Min Huang, who is an adjunct professor as well as a staff attorney at the Legal Advocacy for People with Cancer Clinic. And they will be presenting at our April and May seminar as well. And today, Kathy will be leading today's presentation. And so, Kathy, I'm going to turn it over to you. And then we can begin.
Great, thank you so much, Ali.
Of course.
Let me see if I can do this. All right, let's see. Okay, can everybody see my slides?
Mm-hmm.
Okay, wonderful. So thank you very much. This is just such an exciting thing to be part of. I was just thrilled when Dr. Hester approached Min and I and asked if we would participate in this educational opportunity. And we didn't even hesitate because this is what we do every day. The Legal Advocacy for People with Cancer Clinic is a medical legal partnership between Karmanos Cancer Center and Wayne State, where law students have the ability to help individuals diagnosed with cancer at Karmanos who can't otherwise afford an attorney get their legal issues addressed. And healthcare is absolutely, health insurance is absolutely one of those issues. We actually help in a lot of variety of ways with employee benefit issues, life planning issues, public benefit issues, some housing issues, and of course, health insurance issues. So this is something we've been doing for about 10 years now with Karmanos Cancer Center. And so we wanted to have this opportunity to bring some of the information that comes across to us a lot from our different patients that we work with, our clients that we work with. Putting together the fundamentals of health insurance in 30 minutes was quite the task. So I will apologize up front to say that I'm not going to be able to clearly cover everything that is possible to speak about health insurance, but I wanted to give some of the basics about the different kinds of health insurance out there and give some examples of cost. And then we're going to leave about 15 minutes, I think from about like 5:15 to 5:30 for Q&A. So please feel free to use the chat to start putting your questions in. And then the lovely folks in charge are going to be monitoring that. And when we come to the Q&A section, they're going to be throwing out questions to Min and myself. Min is the staff attorney that works with the clinic. So he helps supervise the students that we have every semester in these types of cases. So we're more than happy to try to answer as many questions as we can in the Q&A section, and I will get started with the presentation. So I just wanted to put out a disclaimer that even though I'm an attorney, I don't want you to take this as legal advice from your personal attorney. This is just an informational session. However, if there's something that we talk about today that you think, wow, I could really, use some more advice on that or some more direct representation, by all means, feel free to search out an attorney in the area if you're not sure how to find one. We're going to leave an email address at the very end where you can definitely email Min and I, and we can see if we can connect you with some of the local legal aid organizations, or if you're a Karmanos Cancer Center patient and qualify for our services, we can always help you as well that way. Okay. So I just wanted to give, I also wanted to give a little shout out to Lucy Rosa and Brianna McAuliffe. They're two advanced students in my clinic who really helped to put a lot of this information together. I asked them to sort of think about when they had to learn about health insurance as law students, what were some of the things that, they fundamentally needed to know. And so they helped a lot in designing these slides. So I wanted to also give them a shout out. These are the types of things I'm going to cover today. Just giving you an overview of the different types, especially private insurance and public insurance, which are pretty much your government insurances. I don't know a ton about VA and TRICARE, so I'm not going to cover that today, except to say that when people have VA insurance, primarily getting their care at a VA institution is how that works, Veterans Administration institution, and usually most of their care is covered pretty comprehensively. It's just sometimes the inconvenience of having to go to a VA site specifically. So other than that, I'll be covering Medicare, Medicaid, private insurance, and then also talking about how to purchase insurance off the marketplace, which is something that became available after the Affordable Care Act that was passed in 2014. And then I just give some final thoughts about bills and explanation of benefits and what it means when you get a bill, and the kinds of actions you might want to take and not want to take, et cetera. And then definitely being open to any questions that you have to as I sort of go through these different topics that will come up to mind. So a lot of the common issues that come up for us in our clinic are things like, we'll get clients that call us and say, you know, I had to leave work and I don't know if I can take my health insurance with me. I don't know if I have to get new health insurance. I'm not sure what to do. And I'm currently receiving cancer treatment. I don't want to break in my coverage. I don't want to have to change providers. Can you help us? So that comes up a lot when you're sort of moving in between either jobs or having to leave a job for a period of time. COBRA, a lot of individuals don't know what COBRA is. COBRA is basically the federal right to be able to take your insurance with you when you leave a job for a period of months afterwards and continue it while you wait to get new insurance either from a new job or through the government. And so a lot of people don't understand the rules around COBRA. We're going to talk, I think it might be in April or May, I can't remember which month, a little bit about employee benefits. And we'll talk a little bit about COBRA more then, because it really does have to do with your employer. But I'm happy to answer any questions about it tonight that I can. And then billing the wrong health insurance plan. Yes, mistakes are made, especially in financial patient financial services, where, you know, you may have the fortune to have maybe 2 or 3 different health insurance plans, maybe through a spouse, a family member. You may have a private one and then a government one. And then sometimes the wrong insurance plan gets billed. So it's not that you don't have coverage. It's just that the provider billed the wrong insurance plan. And sometimes just fixing that problem can get the coverage that you need. Unpaid medical bills. A lot of individuals just say, I don't know what to do. I have all these medical bills. Where do I start? Can I just ignore them? And of course, the answer is absolutely not. Please do not ignore them. That's the worst thing you can do. And actually taking a firm sort of grip of them and figuring out where they're from and getting on some type of managed payment plan is really a great way to keep yourself out of collections and out of having potentially some hit to your credit rating. Some laws have been passed to try to actually make that not be the case if you have health debt, to not worry about that. But I just think if you can take charge and get out of payment plan, you just feel better, because now you're not worried about opening that mail because you know what's coming and you know how you're in charge. We talk a little bit about that at the end too. And then unable to afford co-payments, so kind of being what I like to refer to, a lot of people in the industry will refer to being underinsured. So I have insurance, but it's not enough because there's still a lot of costs on my end. And then 20%, a lot of individuals don't understand that Medicare, while it's covers a lot, it also only covers at 80% when it comes to all your outpatient procedures, or most of them, I should say. And that 20%, unless you choose a different plan, like a Medigap plan, you're going to have some costs. And so a lot of individuals aren't necessarily counseled on making sure they choose that when they enroll in Medicare. So my students found some statistics. You know, students, they love statistics, and I thought these were very interesting, just to get a sense of where a lot of Michiganders are insured. And as you can see, it's not surprising, large amount from an employer-sponsored plan. And then, of course, there's still almost 20% that are funded through the state government, which is Medicaid, and with some help from the federal government, and then Medicare, which is primarily a federal insurance plan. So just get an idea of kind of how it's spread out in the state of Michigan. And health insurance, just so you know, is is governed by state laws. So yes, there are definitely some federal laws, like Medicare is a federal program, but private insurance is handled through the state. So the laws that affect private insurance is handled through the state, and the same thing with Medicaid, that's through the state. So just to get a sense of that, that's why there's DIFS, which is the Department of Insurance and Financial Services at the state level. It's a great website. So Department of Insurance and Financial Services. It's a great website to learn about health insurance in the state of Michigan. They have a very consumer-friendly portal that talks about health insurance. They even have like a 30-minute webinar on health insurance from one of their staff, talks about different things. And then they have a great list of glossary of terms and et cetera. So they're really trying to help the people of Michigan understand health insurance and their options. These are a lot of definitions that people come across that they confuse. They don't exactly know what they mean. They've seen them, they've heard them, but it's really important to appreciate that with health insurance, there's costs involved, and the costs vary from plan to plan. And the costs are very different. So premiums is the monthly cost for health insurance. Any insurance, we have premiums, right? Sometimes with our car insurance, we pay our premiums maybe twice a year or quarterly, let's say. House insurance, we might pay our insurance monthly, we might pay it twice a year, we might pay it once a year. But whenever we have insurance, life insurance, whenever we have insurance, there's some way that we're paying premiums. And with health insurance, for the most part, it's a monthly premium. Okay. For people who are employed, most of the time that's a direct, it's taken directly out of their paycheck. So pre-taxes, their contribution is taken out and paid directly to the employer to pay for that benefit. When people have private insurance, then they will write the premium check themselves. And then for individuals who have Medicare and are receiving Social Security, a lot of times their Medicare payment is taken out of their Social Security check before it's deposited into their bank account. Okay, so premium is just the monthly cost. It doesn't change except for year to year if the premiums go up or down. But month to month, it doesn't change. Once you have a premium, you have a premium. Premiums have to be paid in order to have insurance. It's really important to know. So one of the things that happens is sometimes individuals, when they leave or separate from work, not knowing if they're still covered under their employer's plan is really important, because if they are still covered, and some smaller employers will say, Kathy, you are a phenomenal employee. We want to still cover you under our plan, but you're no longer working. There's no paycheck to remove the premium from. So you just have to mail in the premiums every month. And here's where you need to mail them in, et cetera. And that's really important, because we have individuals who are so used to getting their premiums taken out of their paycheck that when something changes, while they still might have coverage, how it gets paid might have to change. Deductible, just like with any other insurance, it's the amount that you pay for the medical services before coverage kicks in. So if you have a deductible, let's say you have insurance that will cover 70% of all costs and you have to pay 30%. Well, that doesn't even kick in until you meet the deductible, and the deductible can be zero. Some plans have zero deductible, meaning the 70-30 split happens right away. Some insurances have a higher deductible. And so that money has to be paid up front before then the co-insurance. And the co-insurance is, just like I said, it's the difference between what the insurance will pay and what you will pay. So different plans are 80-20, 70-30, you get the idea. Usually the higher amount that the insurance company is paying, then usually there's a higher premium. So if it's a 90-10 split, if the insurance company is paying 90% of the cost and you're picking up 10%, there's a good chance your premiums are going to be higher versus a plan that's like an 80-20 split, where the insurance company is paying 80% and you're paying 20%. Copay is the out-of-pocket cost that you're responsible for, and coinsurance is, the percentage. Copay is usually an actual amount. So sometimes it can be a percentage, but for example, a lot of people have like $10 for every office visit or $30 for every office visit. And so that's just their copay. No matter how many times they go, their copay is always going to be that. And then out-of-pocket maximum. So their out-of-pocket maximum is the maximum amount that you will pay in any calendar year for your healthcare cost. but that doesn't include premium. So I want you to understand that. So if my out-of-pocket maximum is 10 grand, no matter how much health services I need, even if it's several thousands and thousands of dollars, I'm only going to have to pay $10,000 in that care. So like, let's say it's a 90-10 split. All my bills are paid 90% by my insurance. I pay the 10%. Once my 10% has come up to $10,000 and I paid it, my insurance then kicks in at 100% and pays the rest of the bills for the rest of the year. Okay. I don't have to pay more than my out-of-pocket maximum, but that does not include the premiums. The premiums still have to be paid every month. They do not go to that out-of-pocket maximum. And that's just very important for people to understand. So the types of insurance, primarily public and private. So today I'm going to try to cover both and give you a sense of the difference between the two. Okay, so public, you're sort of thinking of government-sponsored insurances, like we said, at the state, the federal government, and through the military. And then private would be through your employer or on the marketplace. So Medicare, I wanted to start with Medicare because that's one that comes up a lot with individuals that we see in our clinic, especially. So Medicare is, it's funded by the federal government. You have to be a U.S. citizen or a legal resident for at least 5 years. And it's primarily broken down into 4 parts. So that kind of confuses people as well. So I want to talk a little bit about that. So it's a federal healthcare plan. Okay. So to be eligible for Medicare, most people become eligible for Medicare when they turn 65. That's when most people get it. But other individuals can get it, especially a lot of people who we see in our clinic, once they've been receiving Social Security disability insurance payments for 24 months. So if you've been deemed disabled by Social Security and you start to collect a benefit check, once you collect 24 of those checks, you now are eligible for Medicare. Okay. And then finally, if you have ALS or end-stage renal disease, you're automatically eligible for Medicare. So those are the individuals who are eligible for Medicare. Medicare has 4 parts to it. Okay. So for anybody who's held a job and has had taxes taken out of their paycheck, you'll see things like FICA taxes, state taxes, and then you'll see something called Medicare tax. That Medicare tax, think of it as the premium for your Part A. So if you've paid into the system long enough, when you're eligible for Medicare, whether you're become disabled or whether you turn 65, your Medicare Part A doesn't cost anything. Okay, the premiums have been already paid through your taxes. So you get Medicare Part A at 65, no premiums. And there's something I want you to think about, which is called coordination of benefits. Many individuals are working over the age of 65, love their job, need to work, whatever reason, they continue to work. So they may have insurance through their employer, and now they're eligible for Medicare. So what you want to do is you want to talk to your employer to see which health insurance is primary. It really depends employer to employer. Obviously, a lot of employers like Medicare to be primary because why not have the federal government pay for it and then they become secondary, okay? But it's just very important that you know that if you're still working and you're receiving Medicare, how your benefits are being coordinated. Okay? Then Part B, so Part A is primarily like your inpatient services. So primarily being hospitalized is covered by Medicare Part A. But we have other healthcare costs, laboratory, when we go to the laboratory, get labs drawn, any durable medical equipment, any outpatient visits to our doctor's office, those come under what's called Medicare Part B. And Medicare Part B has a premium to it. And so that's something that you have to purchase when you become eligible at 65. Medicare Part D, I'm going to skip C for a second. Medicare Part D is another part, and that has to do with prescription drug coverage. So you pay a premium for that, and you get prescription drug coverage. Medicare Part C is called an Advantage plan or Medicare Advantage plans. The enrollment for that is the beginning of the year. So I'm sure like all of you, you've seen a million commercials for Medicare Advantage plans. That's because the open enrollment just closed. That combines sort of Medicare kind of A, B, and D together. So if you choose a Medicare Part C plan, it kind of has different costs, different cost structure to it than the other ways. And I'll go through that, just explain a little bit. And the other thing that people don't realize is there's also something called a Medigap. And Medigap is Part B only pays 80%. Part A pays 100%. Part B only pays 80% of healthcare costs. So who's going to pick up that other 20%? So most individuals will purchase what is called a Medigap policy, which they're particular policies. Different companies can have them. They're like A through J, so Medigap A, Medigap B, and Medigap C, but different companies can offer the same plan. So like Aetna can offer a Medigap A, Blue Cross Blue Shield can offer a Medigap A, and they can be a little bit different cost and different providers, clearly, who's ever in the Blue Cross Blue Shield providers, whoever's in Aetna. So, but the Medigap covers the 20%. So when you think about the cost for Medicare, this is what a lot of people really start to go, wow, I thought Medicare was going to be my, saving grace. And it turns out Part A, so you think about like your monthly cost, Part A, there's no monthly cost. Part B, the average monthly premium is $164.90. So about $165. And that can vary based on your income, but that's the standard. Then Part D, which is your prescription drug coverage, is the average cost is about $30. And again, that can go up or down depending on the plan you choose. And then Medigap, the same thing, depending on the plan you choose, the average monthly premium is about $128, but that can change. So when you think about having Medicare coverage to really cover your medical expenses, you've got to take your Part B premiums, we've got about $165, plus your Part D, plus a Medigap. So it can be $300 to $400 to $500 for somebody to have Medicare when you think about the cost of the monthly premiums for Part B and Part D and for Medigap. Now, if you pick Part C, you don't pay for Part A, you still have to pay for Part B, but then Part C will fold in usually the coverage for the Medigap and for Part D. If you have a Medicare Advantage plan, you can't choose a Medigap policy. It doesn't allow you because Medicare Advantage is taking the place of that. So that's why a lot of individuals will choose a Medicare plan, because a Medicare Advantage plan, because of the cost. What's so important to understand is who the providers are. Okay, Medicare Advantage have specific providers. Medicare, okay, is traditional Medicare Part A, Part B is it's not as restricted as Medicare Part C when I'm talking about like the pool of providers that you can get from. That doesn't mean you shouldn't get a Medicare Advantage plan. It just means that you want to make sure your oncologist, your healthcare team is in network for your Medicare Advantage plan. Now, when people say, wow, Kathy, that sounds like a lot of cost, is there any way that I can minimize that cost? And the answer is yes. If you have a particular income amount and resource or asset limit, there's the Medicare Savings Program, which is run by the state. And the Medicare Savings Program allows for individuals who have limited income and limited assets to actually get your Part B premiums paid for, your Part D premiums paid for, and can also cover some of the Medigap costs. So it's just important that if your Medicare costs are quite high, to call down or go online to the Department of Health and Human Services, because the Medicare savings programs, you could be eligible for it, and that could reduce some of your out-of-pocket costs by reducing some of those premium costs for the Medicare programs. Okay. So now we have Medicaid, and I'm going to talk a little bit about how the two work together. Medicaid is funded primarily by the state, and it's insurance that is pretty comprehensive. So some individuals on Medicaid will have some small copay, but other than that, there's not a whole lot of cost when it comes to Medicaid. It's pretty, like I said, there's some small copays, but that's about it. Traditional Medicaid. So before the Affordable Care Act was passed in 2014, in order to get Medicaid, and Medicaid's run at the state level, so I'll talk about Michigan, in order to be eligible for Medicaid in the state of Michigan, you had to be in one of these categories. You either had to be a child, you had to be a woman who was pregnant, you had to be an individual who was disabled, and you had to have low income and had to have minimal assets. If that was the case, the state would cover your insurance, okay? So if you think from it from a perspective of the state doesn't want its residents to go without health insurance. So those individuals who can't afford it, we're gonna provide it this way, thinking that most other people were getting it through work or maybe on Medicare. But the truth of the matter is a lot of individuals didn't fall into these categories and couldn't get Medicaid. So when the Affordable Care Act was passed, Michigan opted in for expanded Medicaid. So that's Healthy Michigan. So when you look on your screen, the traditional Medicaid that I just spoke about talks about your income has to be limited 100% of the federal poverty level. The federal poverty level is released every year. And I think it's about $18,000 a year for a single individual. That's what the federal poverty level is. So if you're at the federal poverty level and you have a lower income or low assets, you were eligible for Medicaid. Well, because that was so restrictive and a lot of individuals didn't qualify, Michigan opted into expanded Medicaid. It got rid of the asset test. So you can have as much money in your bank account as you want. You could own 2 homes, 3 homes, 5 cars. All that mattered was your income. If your income, and they raised it, and so instead of 100% of the federal poverty level, you could bring in monthly income up to 138% of the federal poverty level and still be eligible for Healthy Michigan. And you did not have to fit a category except being between 19 and 64 years old. So you didn't have to be disabled. You didn't have to be pregnant, okay? So Healthy Michigan is what a lot of individuals in Michigan are now enrolled on. When they're enrolled in Medicaid, they're enrolled in Healthy Michigan. But it's really important to understand that's a primary insurance. So what do I mean by that? A lot of individuals who have cancer may be unable to work, and so they don't have insurance through their employer, so they're getting it through the state. They're on Healthy Michigan, no premiums. Everything's getting covered. It feels great, less to worry about. They can focus on their cancer treatment, and they apply and are eligible for Social Security. And after being on Social Security for a couple years, they now have to switch to Medicare. They lose Healthy Michigan. They no longer can have, even if they want it, they can't. The state's always going to say, nope, we want the feds to pay the bill. So at that point, then Medicare becomes their primary. You can still get Medicaid as a secondary, but it switches back to the old Medicaid. Okay, so you have to fit the old Medicaid rules with lower income, lower assets, and then you can have both. And that's people that are called dually eligible. And we'll talk about that in a second. So I just wanted to give an example because this comes up a lot, especially with individuals who are trying so hard to manage their cancer treatment and trying to deal with work and lower income, et cetera. So let's just say your income was about $1,500 a month, which is right around, I think, a little bit above the federal poverty level. You owned a second car and had a savings of $5K, okay? So you wouldn't be eligible for traditional Medicare, but you'd be eligible for Healthy Michigan, so you have Healthy Michigan. But then you had to leave work and you started to receive Social Security disability for 2 years, about of the same amount of money, and you still owned that second car and had a savings, okay? You're not gonna be eligible for Healthy Michigan, okay? And you're not going to be eligible for Medicaid as your secondary because you do not fit the traditional rules for Medicaid. So that means on that little bit of money, you're going to have to go ahead and pay for Medicare Part B, Medigap, and Medicare Part D. But remember, you might be eligible for those Medicare savings programs. So even though your income is low and you had to lose your Medicaid, you might still have an ability to get some savings through the Medicare savings program. This is what I talked about when individuals are duly eligible. So some individuals, okay, if their income is lower, closer, this is the federal poverty level. Somebody is an individual, their income is $1,100 a month, okay, and they were on Healthy Michigan, but then they ended up using up a lot of their savings, got rid of that second car. So now they're under the resource limit. They're at the federal poverty level. They have to go on Medicare because they've been on disability for 2 years. They can keep Medicaid, traditional Medicaid, as a secondary. So they can be what's called duly eligible. They have Medicare as their primary, they have Medicaid as their secondary. And with Medicaid as a secondary, the state usually picks up the premiums for Part B. Medicaid is the provider for the prescription drugs, and picks up any of the 20%. So there's no need for a Medigap policy. So individuals who have very, very little assets and very, very low income and are eligible for Medicare are usually eligible for Medicare, Medicaid, and they have very, very few healthcare costs. Okay. So the other type of health insurance is private health insurance. And we talked primarily, that was public health insurance. And so when you think about private health insurance, you'll hear these terms a lot: HMO, PPO, EPO, exclusive provider organization. What this is, and when you get it through your employer, which is where a lot of people get their insurance, HMO, it's health maintenance organization. It's where you have a primary care physician or a PCP, and that person's like they're sort of like the gatekeeper, and you need to get all specialty referrals through them. Now, what the thought is that with that, healthcare is being used in a most expeditious way, in that you're going to your primary care physician who knows you well, and you're saying the symptoms coming up, and he or she, if they can't address it because it's not their specialty, then they go ahead and they make a referral to somebody else who's in your network. You go and that's covered. And so the idea is that somebody is kind of overseeing your care from a one point, if you will, perspective. It's limited in that you can only go to the people in network, and your provider has to provide a referral, except for certain types of covered things, like, for example, a mammogram is covered every year, and that is not something you need necessarily a referral for. There's some other things that are covered, like a one-time wellness exam, et cetera. A PPO is very similar, except, most people have a primary care physician, but a PPO is you don't need the referral. You still have to stay within network. But you don't need the referral. You can just call up and make the appointment at the specialist yourself. The premiums are what are different in plans like this. Usually an HMO premiums are less expensive because it's more controlled cost. A PPO premiums are usually a little bit more expensive. So depending on how much healthcare costs you think you're going to have in a year, if you think you have to see a ton of specialists and you don't want somebody else to tell you who you have to see and get all those referrals, some people will then opt to go on a PPO plan through their employer because they have a little bit more freedom on who they can choose. One of the things to remember when you choose a plan through your employer is plans, open enrollment happens in the fall every year. So between October, I think it's like the last couple of weeks in October, you can change. So a lot of people, let's say they did an HMO for last year. In October, they might have said, you know what, this doesn't work for me. I want to switch to a PPO. And then they switched to a PPO. And then starting January 2023, now they're on a PPO. If that doesn't work, come the end of the year, they can go ahead and change and go into a different one. So that's one thing about employer-sponsored insurance. It's not like once you're in one category, you have to stay in it for your remainder of being employed there. Okay. So if you can't get insurance privately through your employer, then you have to go on what's called the marketplace. And this is all because of the Affordable Care Act, right? So we have a lot of individuals who can't get it through who can't get it through their employer and may not be eligible for Medicaid or Medicare because they're working, but they can't get it through their employer. Okay. So the marketplace is where you go to purchase privately health insurance. And in Michigan, it's healthcare.gov. So we didn't make our own private portal. We use the one that the federal government designed, which is healthcare.gov. But when you go into it, you put in all your Michigan specific criteria, and it helps you find a plan that you purchase on your own that covers your healthcare needs. Okay. There's enrollment periods, just like there is if you were purchasing it from an employer. And sometimes things happen that where you miss an enrollment period and you may be eligible to specially enroll. So something happened, if you got married, if something changed in your family and now you miss the enrollment period, if it's a special circumstance, you can even enroll outside of the special enrollment period. Okay, so this is what qualifies for special enrollment. So if you miss the time that you were supposed to enroll, changes in your household, changes in residence, you move somewhere, loss of health insurance, so you lost your job, you don't have health insurance anymore, you became a U.S. citizen, or you're leaving the prison system, coming into civilian life, and you need health care. Even if you miss that special enrollment, you can still enroll in the healthcare marketplace. Okay, that's why today when I went to the website and did a screenshot, it said still need health insurance, because it's over with enrolling for 2023. It's done. That's why they're saying, oh, you may qualify for a special enrollment. Why don't you answer our questions to see if you qualify? Otherwise, you have to wait till the end of the year to enroll. Okay. So when individuals say, well, Kathy, if I buy it through healthcare.gov, what does that mean? And what it means is it has to be a qualified health plan. It has to have particular essential coverage. Otherwise, it can't be listed on there. And there are different plans. As you can see, platinum, gold, silver, bronze, expanded bronze. That's actually the types of plans. And based on that, you pay so much, your insurance coverage pays another amount. So obviously, the higher insurance coverage of 90%, those premiums are going to be higher than like a bronze level, which only covers 60%. Okay. That's how that works. There's different levels and you can pick which level. The essential health benefits. A lot of people will say, well, will my cancer care be covered? And the answer is yes, for the most part. Anything that you choose on the marketplace when you go to healthcare.gov. I'm not talking about going to a private insurance salesman. I'm talking about going through healthcare.gov, because those are guaranteed to have these 10 essential health benefit coverages. And they also must include birth control and breastfeeding coverage. Okay, so these are the cover. Any plan on healthcare.gov has to have this kind of coverage. And when you're thinking about, well, my income, is not as high as I'd like it to be, do I get any savings if I go through healthcare.gov? And the answer is yes. Based on your income through the Affordable Care Act, it was that your premiums can be no more than a particular percentage of your household income. So the government was trying to make it affordable. That's why it's called the Affordable Care Act. People argue whether it's really affordable, but I'm telling you, there are some discounts. So if you want to go into healthcare.gov and you don't know how to start, you can go to find local help. .healthcare.gov or localhelp.healthcare.gov, and you'll find local individuals in the greater Detroit area who have been trained on how to manage healthcare.gov website and can actually help you go through, print out plans and compare plans before you choose one to see what the actual cost will be to you. So I really highly suggest that, because it can be a little bit unwieldy to go through healthcare.gov by yourself. So if people say, well, Kathy, how are the savings work? If your income is anywhere between 100% and 40%, 400% of the federal poverty level, you can get a break in your premium. So if the federal poverty level is about $1,200 a month for an individual, but they were making 4 times that, 400%, they can still get a break in their premium. Okay. Even if it's above 400%, you can still get a break in your premium. You can even get additional savings if you choose a silver plan. So the government carved out silver plans, which is the 70-30 plan, to say that if you choose a silver plan, we can even reduce some of your co-pays as well. So a lot of times when people go on, they'll look more at the silver plans because there's even some more savings there. I'll just give you an example. These were the federal poverty levels for last year. So you can see an individual who's at 266% of the poverty levels is an individual who's making about 36 grand a year. So if I was making about 36 grand a year, I put my information in and you can see what happens here. So I say Michigan, I gave a zip code, where I live, and then I went ahead and I did what my income is going to be, 36,000. And then I'm an adult. It does ask if I'm using tobacco, because some of you had asked earlier to Dr. Hastert, you put some questions ahead of time. And one of them was, can I be dinged for pre-existing conditions in health insurance? And the answer is no. The Affordable Care Act got away from pre-existing conditions. So you do not get a higher premium or denied if you have a pre-existing condition. However, you can get a higher premium if you're a tobacco user. Under the law, they're allowed to raise the premiums if you're a tobacco user. So by plugging in this information, so age, et cetera, then it told me what the results are. And as you can see, the plan, the cost would really be $260, but because of my income, I get a break and the cost ends up only being $140. So there's actually a decrease in the premium every month for me because my income meets a certain threshold. And it's not a tax credit you get back when you do your taxes. It's a tax credit that gets applied and your premium is cheaper every month. Okay. All right. So again, I just wanted to show you. So in this case, my premiums would be $140 a month, but I would have to pay those for 12 months. So my premiums would be about $1,600 for the year. And my out-of-pocket maximum can only be $9,100 under the Affordable Care Act. So at most I'll pay is $10,000 for the year. That's still a lot of money, but at least it's a known number. It's a known number of what I need to plan for. So here's some final thoughts. The Affordable Care Act, pre-existing conditions, this is health insurance. This is not short-term disability, long-term disability, life insurance. Those are different kinds of insurances. But health insurance under the Affordable Care Act can no longer discriminate if you have a pre-existing condition. You're still eligible. You cannot be denied, and your premiums can't be higher than somebody who does not have that condition. There's no annual limit. Before the Affordable Care Act, your coverage could be limited annually for how much your health insurance company, let's say Blue Cross Blue Shield, would cover. It's not anymore. And there's no lifetime limits. So Blue Cross Blue Shield can't say to you, can't say to me, Kathy, we've already spent way too much on you, we're done. They can't. There's no lifetime limit. There's no annual limit. Okay. The only thing is they can put some limits on if it's a service that is not one of those 10 essential health benefits. Okay. So knowing when and what to pay. This is really important because a lot of times people will say, I got this thing that says what I might pay, should I write a check? And the answer is no. That's what's called an explanation of benefits. It says, hey, Kathy, you may have to pay this. I want to wait till I get an actual bill that says, Kathy, this is what you have to pay. So just an explanation of benefits has to come from the insurance company. Under the law, they're obligated to tell you what your costs might be. When you get that, if you don't agree with it, it's a great time to start arguing and figuring out what's going on. But when the actual bill comes, that's what's telling you what you have to pay. And if the bill's wrong, again, call up your insurance, call up your provider, say what's going on. Make sure you understand the bill before you pay it. If you are arguing with the bill, like with the Blue Cross Blue Shield, call up the provider, call up your doctor and say, I don't agree with this bill. Please make a note in your financial record of me that I'm disputing this bill. Don't send me to collections. And they usually won't, because they understand that you're out there, that you're trying to do something, and they'll usually give you like 30 days or 60 days or some period of time to try to resolve it. You request a payment plan. I tell people to do that a lot. I've had clients who pay as little as $5 a month because that's all they can afford. Even if their bills are hundreds and hundreds of dollars, at least the entity, the provider, knows money that is coming in. If you've been denied coverage for a particular service, you can appeal it. The state will even help you with that, but the state requires you to go through the internal appeals process with your health insurance first, and then go to DIFS, the Department of Insurance and Financial Services, and they will help you with an external appeal. So you actually have help at the state for free. They don't charge you, but they can help you appeal it again to see if you can get it approved. So these are some questions just to ask yourself when you're thinking about insurance. Am I eligible perhaps for public insurance as opposed to privately paying? Which type of coverage would be best for me based on my cancer, based on my treatment, based on my expected treatment? How much will my medical services cost over the year, including my premiums? And do my physicians accept a certain plan? Because I really like my physicians and I want to change plan. I want to maybe go from Blue Cross to Aetna, but I want to make sure I can still see my oncologist. And if you have any questions that we don't get to today, this is the email address for my office, lepc@wayne.edu. The individuals who see it are my students, and hold on one second. My students are the ones who see it, as well as Min, my attorney, and so the staff attorney, and that's it. And so between Min and myself and the students, perhaps we could be able to answer your questions.
Thank you so much, Kathy. That was a great presentation. Very, very, very informative. And as a few people mentioned in the chat, Anuja, there are a couple of questions if you want to.
Yep. All right. So first question, Dr. Thompson had presented it. Do most people have Medigap or even know how to purchase Medigap?
Great question, Dr. Thompson. The answer is a lot of people do not have it because nobody's necessarily talked to them about purchasing it. When they know about it, or if they talk to their friends, they'll usually get it and purchase it. It's just a matter of when people become eligible for Medicare, actually sitting down with somebody maybe who has Medicare and walking through with them to know. Social worker at the hospital. Social workers at the hospital are really good at making sure people have purchased Medigap or know about it, because that 20%, especially in cancer care, can be excruciatingly costly.
Thank you. Our next question is, what is the average cost of Medigap if you don't choose Part C?
Medigap, I think I was reading online today, it can be variable depending on the deductible that you choose. But I've seen Medigap policies that can be relatively low, like $30 a month, and then Medigap policies that can be well into like almost $200. So much of it depends on the deductible, because obviously the higher deductible, then the lower the premium. But I know premiums can be as low as $30 and premiums can be as high as almost $200.
Thank you. Okay, some more questions. Is there a limit where insurance won't pay anymore? Also, annual out-of-pocket max differences in insurance is there an out-of-pocket max difference when working or not working?
The out-of-pocket max, so I'll start with the second one first. The out-of-pocket max has to do dependent on the insurance type and your income. So it really has to do with income. So your out-of-pocket max is never supposed to be more than a particular percentage of your income. So whether you're working or not working, it has to do with your income, what income is coming into the home. So it can differ, but it's sort of set under the Affordable Care Act. So as you start to look for insurance plans, you'll know what the out-of-pocket max is, because they have to state what it is. And just repeat that first question. I'm sorry.
Is there a limit where insurance won't pay anymore?
The only limit that the answer is yes, if it's particularly, let's say, like a limited service. Let me give you an example. So let's say under your insurance, you have 30 physical therapy visits in a year. Well, once you hit 30, it's not going to pay for number 31. It's just, if there's a limited, if the coverage itself is specific, then insurance isn't going to pay if you take a service that you have already maxed out the allowed amount. The other time it might not pay is if you went out of network and didn't get pre-approval, or if you, like I said, like sort of maxed out and you're then continuing a service, then no, they're not necessarily obligated to pay. Sometimes what's important is when you work with like a physical therapy, if your physical therapist can see that you might, it might be advantageous for you to continue. Sometimes you can negotiate with an insurance company and they will actually extend a benefit, because why? They'd rather have you be active and functional than land back in the hospital, which is much more expensive for them. So sometimes when you know you're going to run out, it's worth making a phone call to the insurance company to see if they can, by any chance, get you into like a managed care department in that and company to see if they can finagle a benefit to get a little bit more out of it.
Thank you. So I think most of the participants on this webinar are from Michigan, but could you please decipher between what is state versus federal
Sure.
with the Medicare, Medicaid?
So Medicaid is state. So if you have Medicaid in the state of Michigan and you move to Wisconsin, you have to get Medicaid in the state of Wisconsin. You can't take Michigan Medicaid with you, just like you can't bring Wisconsin Medicaid with you, okay? Medicaid is very state specific. Medicare is not. Medicare is federal. So if I'm traveling, if I have Medicare and I'm traveling to Arizona and I need to see a doctor and they take Medicare, they're going to take my Medicare, even though I live in Michigan, because Medicare is Medicare, unless it's an Advantage plan. Medicaid is different. Medicaid is very state specific, okay?
Thank you. What will the insurance cover, and how do you find out what your insurance will cover?
Okay, so I think, so a lot of people don't know what their insurance covers until they need to know, right? So, I mean, if you ever read your insurance coverage, it's just huge, right? Oh, it covers this, it covers this, it covers that. So it's usually when people say, oh gosh, I need physical therapy, let me go look at my plan to see what it covers. So if you're anticipating a particular kind of treatment, the two things that I would suggest is, one, you get a copy of your insurance plan, whether it's from your employer or the insurance company itself, to see what's covered. I would talk to somebody over at the insurance company to say, hey, I'm reading this. It feels like it's Greek to me and I don't speak Greek. Can you explain to me what this means when you say that you cover chemotherapy? I'm not understanding. It sounds like that you'll cover maybe if it's IV, but you won't cover if it's by oral, etc. So talking to somebody at the insurance company, then I think it's also really helpful to talk to the provider who's going to provide that actual treatment, because they usually know how easy or how cumbersome it is to get reimbursement from that particular insurance company. So a lot of times, you know, the insurance company might say, oh yeah, we cover it. Then you talk to your physician, their physician says, oh, you've got Aetna. Oh my gosh, they're such a pain in the butt to work with, et cetera, et cetera. So sometimes I think going both ways, finding out from your insurance company what they're supposed to cover, and then find out from the provider if they've worked with that insurance company and how easily it's been covered. Because the last thing you need to do is spend a lot of time arguing between between the insurance company and your physician, when you just really need to be focusing on your treatment.
Thank you.
Excellent. Thank you so much. Oh, go ahead, Ali. Sorry that we're going to wrap up now.
Thank you. Thank you both. Thank you, Kathy. So I'm gonna share my screen one last time. I want to remind everyone that we do have 3 more upcoming seminars. We have identifying and accessing local resources. That's going to be a panel. And that's going to be Monday, March 20th, same time, 5:30 to 6:30. We have a employee benefits, knowing and using them. That's going to be Tuesday, April 11, from 5 to 6:30. And then finally, we have an understanding disability benefits happening Tuesday, May 9, also from 5:30 to 6:30. So please be sure to put these on your calendars if you're interested. We'll send out material to the group that registered about registration and whatnot. And then finally, we wanted to ask everyone if you can please complete the evaluation. And I will put the link, or Brandy will put the link in the chat for a chance to win a $50 gift card. So yeah, and thank you all so much.
The evaluation, you're gonna email it for us?
What is it, Abdi?
She asked about emailing the evaluation. That will be sent tomorrow morning.
Yep. Perfect. And if you have any other questions, please feel free to put them in the chat. Feel free to email me. I'll put my email in the chat and I can forward them to Kathy. And then we'll follow up about the slides and recordings and how to access that for those who are interested. But yeah, thank you everybody for attending. Thank you, Kathy, for a phenomenal presentation. And I believe we had one more question in the chat, Kathy, if you had a minute.
Sure.
My PCP is not in the ACA that I plan to use, nor my oncologist. I do not want to change my oncologist. Do I have to choose a plan to one that will accept them, or get a new PCP, or choose a different plan that accepts them, even if it is a lot more expensive?
So the short answer is yes. If you want insurance coverage for care and your insurance provider doesn't work with your physician, then you either have to get a different physician. Now, you can also ask your physician because sometimes physicians are, maybe they didn't use that provider, now they do have they are working with that provider, like Aetna, Blue Cross Blue Shield. So just make sure if you read that your provider isn't in plan, double check with your provider to make sure that they're not. But the truth of the matter is that if you really want to keep your provider and they're not covered in the plan that you have difficult decisions to make. You either have to get a different plan or you do have to get a different provider. Depending on what you're seeing the person for. Sometimes things as simple, and I mean simple, like, for example, I'll just use like a dentist, for example. So like if sometimes people lose their dental insurance, and I remember I spoke to a dentist once and he said, actually routine cleanings aren't really that expensive, that sometimes paying for dental insurance ends up being about the same as getting 2 routine cleanings a year. So depending on what you're seeing somebody for, it could be that even if they're not in your network, what you're seeing them for may be quite affordable. But when it comes to cancer care, that's usually not the issue. It's usually pretty expensive. And so it's really good to make sure that the person's covered. If you have to change providers and you know who's covered, you should work with your current provider to say, these are the list of providers. Is there anybody that you recommend I move my care to? And most physicians, like all of us professionals, will have a professional courtesy and say, oh yeah, I know my friend Bob. He's an excellent oncologist. Why don't you go see him on the other side of the state, et cetera. Okay.
Perfect. Well, that closes out our session. Thank you, everyone. Thank you, Kathy, again. And we hope to see everybody at our next session next March. And we'll send out and follow up with email with the evaluation link and more information about how to access the slides and the recording.
Thank you, everyone.
Thank you.
Thank you.